Assalamu alaikum. Today we are discussing left-sided renal parapelvic cyst. The mobilization of the colon is the same up to the crurum of the diaphragm, so that the gut falls down, and from that level up to the sacroiliac joint. And then we try to identify the ureter. In this case, we performed a left retrograde study, and we also placed a DJS stent into the upper calyx so that injuries to the pelvic calyceal system are avoided. This lady, around 53 years of age, presented with left flank pain, showed a parapelvic cyst, and on a DTPA scan showed moderate obstruction. So we decided to go for the intervention. Here you can see that we are trying to identify the ureter. This is the gonadal vein here, and we can feel the DJS stent inside the ureter. So this is the ureter having a DJS stent. So we grab it with the non-traumatic forceps and we try to dissect the tissue away, so as to follow this ureter up to the cyst. This is the gonadal vein showing the pointer. And this structure seen behind is the parapelvic cyst, and you can see that a structure is crossing. Yes, this one, and this is the upper calyx. Basically what happens is that when there is a parapelvic cyst, the cyst usually arises from within the hilum of the kidney, and it splays the pelvic calyceal system away. So the upper, the middle and the lower calyces are very much long, with long infundibuli, and they are splayed away. So here you can see that now the middle calyx is in picture. The pointer will be now showing, after the dissection, it will be showing the middle and the lower calyces. Yes, this is the middle calyx. This is the yellow arrow is the lower calyx. So we dissect as much as we can, but there is no need for much dissection here, because the cyst is clearly visible, and its effect on the pelvic calyceal system is also visible. So our main aim is not to excise the cyst. We will just deroof the cyst so that the compression effect on the pelvic calyceal system is gone. So this is the ureter having a DJS stent in C2, which is leading to the yes, this is the pelvis, the upper calyx, the middle and the lower calyces. So our main aim is to dissect the pelvic calyceal system away from the cyst, so that we can make a puncture below or above the pelvic calyceal system and drain all the fluid and make a sufficient excision of the wall, so that no more fluid collects there. So we decide that we go for the puncture of the cyst from the above, and then we suck all the fluid, so that when the cyst disappears, you can see all the three calyces with the elongated infundibuli, as well as the pelvis and the stent within the upper calyx. So here we dissect a little more of the cyst from the pelvic calyceal system, and we'll make a big window and excise the wall, which is in fact called the deroofing. So we do deroof this parapelvic cyst, and we keep the stent for 2 weeks. This is the view from the inside of the pelvic cyst, parapelvic cyst. We keep the DJS stent for a minimum of 2 to 3 weeks, and then we will just remove it. The stent is just for protection of the pelvic calyceal system. There is no other purpose. Thank you very much. I hope you enjoyed the procedure. Thank you.